Happy New Year. Welcome back to our first Inspired Approaches to COPD Care post-collaborative webinar. We're having our first part today and part two tomorrow. Today and tomorrow we're going to talk about holding the gains, so sustaining your efforts, as well as extending the reach, scaling up Inspired. So on today's call, I'm joined by our Vice President of Programs, Stephen Samus. Hey, Stephen.
Hello.
We've got on the line Darcy Marcinek, who is the Medical Director of LiveWell COPD, the Chronic Disease Management Program there, and of course a participating team in the collaborative, so thanks for joining us, Darcy. And then in Halifax we've got Graham Rocker, Medical Director of the Inspired Program and our lead faculty for the Inspired Collaborative. So thanks everybody. Here in the studio we also have Claudia Marr. Hey Claudia. Hello. And we've got our producers Kelly and Sheena, and then calling in from New Brunswick is Megan Rossiter. Hey Megan. We also have, and we're grateful that we have many of you, and I'm not sure quite all the teams are on, but it looked like you were all filtering in, so really glad to have you. 19 organizations and participation from every Canadian province has been, I think, a really important factor in talking about the sustainability of this type of work, because it was a common interest that you all had to improve care for people living with moderate to severe COPD, taking an inspired approach. Throughout today's call, so all the teams who are on the line, we want you to think about these questions. And we're going to be talking about these topics, but we would very much like for you to start chatting in your responses and thoughts to these very pragmatic questions. Megan's actually going to copy and paste these into the chat box so you have a reference. But at this point, now more than a year past the collaborative having started, what do you need to sustain what you've started? What do you need to spread and scale up your efforts? So whether you're trying to do that locally within your host organization or your partnership, regionally, provincially, who and what agencies do you think can facilitate that scale? And particularly, how can CFHI help? So a little positioning on our call. When you consider the journey, I think, toward bringing about sustainable at-scale change, this is maybe what an abridged version of that might look like. So you start by thinking about what are the winning conditions for that improvement to take root locally. You need to start seeing early results. You need to begin to win. Then you're moving into that holding the gain, sustaining phase, and thinking about extending the reach. So if I take us back to what we tried to do by way of the collaborative, we really try to focus the collaborative efforts on helping you to assess the local issues, to design a solution, taking Inspired as, I think, a prompt to creativity, beginning the implementation journey, and also starting to evaluate. So you might argue that we spent a fair bit of time in testing mode, that maybe you're now in implementation and considerations of sustainability have become more real now that the seed funding has ended, and that many of you are also thinking about considerations of how to move to scale. So whether that's how can we start to reach all the patients who would stand to benefit in our organization or region, or even maybe you're thinking more broadly than that. So here's perhaps a more pragmatic view of getting to large-scale change. So if you start in that upper leftmost quadrant there, identifying the need for change, that's often where we start. Then you're trying to frame and reframe the issue based on local context. You start engaging and connecting with others. That forces some pragmatic change in multiple processes in terms of how you do things. People are articulating the problem differently and articulating the design of the solution differently. As you bring in more people, you're attracting further interest, causing, again, more framing and reframing of what it is you set out to do. After some time, and maybe some of you are already getting there, you're starting to create a bit of a sustainable norm. Maybe you hit a plateau. Maybe you simply run out of energy or other types of resources to continue those efforts. At a certain point, if this happens in healthcare as with elsewhere, we start to live with the results and consequences of whatever program or initiative that we've set up, until at some point we're identifying a need for further change. It's very similar to what a Federal Health Innovation Panel shared in August of 2015, and sorry, this is a bit pixelated there, but if you actually start above innovation journey to health system needs and priorities, a very similar model. So you start by identifying what those needs and priorities are, you're engaging partners, you're doing your R&D, you're testing, implementing, and at some point you're thinking about What would this look like at scale for an entire province or system? So work from the National Health Service, which continues to rank as number one of Commonwealth Fund countries in terms of health system performance, it does tell us that getting to large-scale change will only be successful if as much thought is put into sustainability as anything else. And it says sustainability is the result of great engagement, reinforcement activities, and a belief in the new way of doing things, which results in a mindset shift. So as much as you're trying to change the day-to-day activity, it's also fundamentally about a mindset difference. So in order to maximize the potential for sustainability, it's really important to start considering it from the start of your work. So how can we ensure that every effort at improvement is highly adoptable? So this comes from Dr. Chris Hayes, who's a medical director at St. Michael's Hospital, and he did his fellowship on this as part of a Harkness Commonwealth Fund CFHI initiative at the Institute for Healthcare Improvement in Boston. So he says it takes considering both the intervention design, what are you asking people to do, and the implementation strategy, how are you asking people to do it? So if you consider for someone who's involved in an implementation strategy, the value that they place on it, the workload it entails, and their capacity to do that workload, I'm going to share with you two scenarios. So scenario one is you haven't well thought out the value that the people who will actually undertake the change consider, that it's going to increase their workload, and they actually have very minimal, if any, capacity to do it. That's going to often lead to burnout, change fatigue, cynicism, error, workarounds. And unfortunately, the intended outcomes will likely not be achieved if you haven't thought about that from the outset. So it's a bit of a reinforcing prophecy. Flip that scenario where you've worked with those who are undertaking the changes to ensure that they believe this will work. They believe it's rooted in the best evidence. It fits the problem scenario that they themselves have seen at the clinical front line. You've thought about how they can introduce it into their workload one step at a time. And you've actually helped create the capacity for them to do it. That's going to lead to a more sustainably adopted improvement intervention that helps to lead to the intended outcomes. Sounds pretty simple. Chris's hypothesis is this, that change initiatives that do not add additional workload and have high perceived value are more likely to be adopted, cause less workplace burden, and achieve the intended outcomes. I mean, this is like holy grail of quality improvement, implementation, and planning, and you're trying to design where there's high perceived value, minimal workload, and the capacity to do the work. So Chris actually looked at a number of high-performing health systems and said, how is it that they are able to ensure that people believe in the work, they've got the ability to do the work, and the capacity to do the work? And he said it's because they continuously ask these very practical questions. So end user participation. Are those who are undertaking the changes, be they physicians or other staff or patients themselves, involved in the change? Alignment and planning. Does the change initiative align with your organizations or your teams or your region's goals, and has the rollout been planned effectively in advance? Are the resources available to implement the change? How much workload is associated with the intervention? How complex is the change intervention? And then importantly, the evidence question. What degree of evidence and belief is there that whatever the intervention or suite of interventions is will lead to the intended outcome? So you've set people up for success. What I'm going to do now is I'm going to turn it over to Graham Rocker. Graham's going to walk us through some updates on the Inspired COPD Outreach Program data from Halifax, and he's going to address some of these issues of sustainability and scale. Darcy has kindly agreed to come back and talk about his experience with this from the LiveWell COPD CDM program from Saskatoon, and just overall his program as a clinical leader in designing and leading new change initiatives. And then Stephen's going to talk to us about what does return in healthcare really mean? How do you construct a sensible business case? And then at the end of each of those presentations, we will be scanning for questions and encourage you to take some time to address Megan's questions that she's kindly posted in the chat box as well. So Graham, I'm going to turn to you for some updates on Inspired.
Okay, can you hear me?
Sure can.
Okay, so I mean, much of this will be familiar with all the teams, but I think some of it does bear a little bit of repetition. So here's just a summary slide of the current design of INSPIRE and with whom we interact, both at hospital level and within the community. You can see there in the boxes, top right, the workload that's basically hospital-centered. And then the other aspects of the plan that play out during the community visits, the 4 visits that we do, the RT visits, the education visits, the spiritual care support visits, a reminder that patients and families have a helpline that they can use during business hours, and our strong focus on, that should be advanced care planning as appropriate. So, next slide, there we go. Now, anyone who knows me will know that that couldn't possibly be one of my slides because I never have more than 3 lines on a slide these days. But this is the kind of slide you might need to put together for persuading your administrators that you really have a good handle on things. So you need to know what your primary outcomes and aims need to be, and what are the primary drivers that allow you to achieve that. So I don't intend to go through this slide in any detail. You all have access to this information and can review these things later. But then there are always secondary drivers as well over there on the right. And these are things that will be influential in how the program plays out and how you might want to kind of reorganize things according to feedback. So, it's kind of a conceptual slide that I think is important in planning out how you might go forward from where you are. And much of this appears in a new implementation package or change package that we have been put together for new teams or old teams that I think encapsulates the ideas and initiatives that, if followed, are likely to lead to some success. So we've stated in a few publications that we've been involved with, and most recently in a review in CHEST that came out in print in September, that was really aimed at a broad discussion of palliative care for advanced lung disease. But in regard to patients with advanced COPD, we did say that without access to reliable alternative integrated models of care, many patients with advanced COPD will resort to episodic or emergency department presentations to manage escalation of their symptoms, and they will remain caught in a repeating cycle of emergency presentation, hospital admissions, and discharge back to the healthcare system that initially failed them to await their next exacerbation or dyspnea crisis. And that is reality for many of us in many of our hospitals currently, and it's still going on, and it's a vicious cycle that somehow we need to break. These are our funding milestones, and just a reminder that INSPIRE didn't sort of crop up yesterday. It was informed by some years of funded research, CIHR and others. We learned a lot from early qualitative research, understanding the experiences of both patients and caregivers of the burdens living with advanced COPD. And so we were able to secure some hybrid funding by various means back in 2010 that essentially enabled us to start a pilot project. This was never really a research study in itself. It was really the knowledge translation, if you like, from earlier research that informed what we felt we ought to implement from what we had learnt. And it took us a couple of years to get core funding from Capital Health, and that was based on presentations of successful data. And likely one of my failings was that I was far too slow getting out of the blocks to talk to influential vice presidents at an earlier stage. And a recommendation that you would have heard many times is to bring on board people you need early on in your initiatives. Take them on the journey with you. Keep them informed about how you're getting on. And Darcy, I think, will talk to this in more detail. And so, as we have benefited from ongoing core funding, there have been a couple of opportunities to expand our program, not by much, but I have to try to continue to be persuasive in this regard, and hopefully, we will from time to time take on extra part-time equivalent, full-time equivalents, respiratory therapists, spiritual care, as we expand in what we're doing. We're seeing more patients who have less severe disease. We have a program running now in the emergency room for patients who come to the Emerge but are not admitted. And that's a research study underway that will run for about another year or so. And so you all know about the Pan-Canadian Collaborative and the 19 teams, and as of 2015, this fall, something like 660 patients currently involved, which is terrific. And we've seen some very good results that in many ways mirror what we were able to achieve in Halifax. And so we have been looking at various analyses as time has gone by. As of June of this year, we had 370 patients enrolled, of which we would consider 178 at the bottom of the flow diagram as constituting a homogeneous group of patients, all of whom went through all phases of the Inspired program and survived at least for the next 6 months. Other patients who drop out along the way did so for a variety of reasons, maybe not sufficient time for full follow-up, maybe didn't have COPD, because we do see people outside that particular diagnosis from time to time. And some didn't see our spiritual care practitioners. But the data that we currently have advertised, as it were, is based on 178 full participants. And so as of June of this year, and you've seen these kind of tables before, perhaps the smaller numbers in the past, for those 178, in the 6 months prior to their index admission, where we started the program for them, there were 365 emergency visits, 210 hospital admissions, and the patients occupied 2,044 days in a hospital bed. And in the following 6 months after the Inspired program, you can see the reductions there, the percentages there in the third column. All of them, Emerge visits, admissions, and bed occupancy down by about 60%. And we've talked in earlier webinars about cost aversion, and based on $1,000 a day for a hospital bed from the Mittman data, 1,230 odd bed days avoided for this particular patient cohort, when you would expect, because of their disease severity, that their bed occupancy would in fact increase rather than decrease. There's a cost aversion here of over $1 million. And if you include me in the costings of the program, then we are still coming in at least twice the annual program cost. So the program pays for itself. We did do a brief, quick economic analysis and published this in 2015 in Clinical Investigative Medicine. And this was based on an earlier cohort where we had 131 patients who at that time we felt constituted the homogeneous group. And by calculating program costs attributable to the various part-time equivalents and how much time they spent on these 131 patients, we came up with this concept of a number needed to save of only 26 patients needing to complete the full program to achieve a cost aversion of about $100,000. And really, I don't think that's too shabby. It doesn't take too long to put 26 patients through a program like Inspired, and $100,000 can certainly buy you a respiratory therapist to help you run your program. And so this is useful data to have when appealing to your financial people at your institutions. Of interest, briefly looking at how we have performed as time has gone by. So all of you in the collaboration are at an early stage relatively. We've been at it for a few years here in Halifax, and in June 2015, you can see the reductions in emergency visits, admissions and bed days there relative to where we were maybe a year ago or 2 years ago. And we're still batting at a pretty reasonable 50 to 60% level. I'm not particularly surprised that we may be down a bit from 72% a couple of years ago. There are more patients, and we are seeing people with a lesser degree of severity. But the important thing is it seems to be a sustained kind of reduction in what we were hoping to achieve. And where I think we win is this very simple concept of reducing the proportion of patients who keep coming back on a repeated basis. So in the early days, look back a couple of years, of the patients who had completed the program, 22% were having 2 or more admissions in a 6-month period, dropping to 4% after the INSPIRE program, and similarly, again, similar number, 21% of our 178 were 2+ admission patients in a 6-month period, and only 9% were repeated at that level after INSPIRE. And so I think this is where the biggest bang for the buck is to be had. It's highlighting those who rely on the facility on a repeated basis and trying to understand why that is and put in place some mechanism so that behavior can change. So we learned along the way, many of you would have seen this slide before. I can tell you that my neighbor's docks does not look like anything like that today out there with the lake frozen. You have to be ready for change. You do need to know your own data. You won't get anywhere unless you look back and see what's been happening in your own institution if you plan to try to change things. Know the processes that are involved throughout your institution and how they might affect you and how you might affect them. And do anticipate barriers and have in place some strategy to overcome them. The naysayers, that we are surrounded by those who take a negative view in healthcare and by those who think, without data, think they've always done it this way for a good reason and they don't see any reason to change. But there's always a reason to change, particularly if it's a change in the positive direction. So we learned that it's important to focus on the quick wins and talk about it. And if you're successful, and I think Darcy will talk more about this, tell people about it. And I think I'll hand over this point to Jen and Darcy.
Yeah, so we'll go straight to Darcy, not seeing questions, Graham, just yet in the chat box. But I'd encourage folks to consider those questions, consider some of the highlights that Graham's referenced. One of the things that we drew from it was that he's continued, the team in Halifax have continued to find research opportunities as a supportive route to continue to sustain and grow their INSPIRE initiative. So we'd be curious to know if others are pursuing a similar sort of research academic-driven agenda, or if there are other sources that you're looking at in addition to that. So it's just one example from Graham's story, but I will pass it on to Darcy, who's going to give us this perspective from his program.
Well, thanks so much, Jennifer. Can you hear me?
We sure can, loud and clear.
Excellent. So my role for the next few minutes was to sort of personalize some of the foundational work that Jennifer spoke to and the experiences that Graham had with his INSPIRE program, focusing on holding the gains, the sustainability, and then looking at scale up if one is presented with the opportunity. So the next slide is dealing with assumptions. So in order to either sustain a program or scale up a program, you need to have a program. So with that means some of the work that you've been doing. And if these assumptions are not correct, if they haven't been met, then you need to kind of stop, pause, and fill in the blanks at this stage. So for instance, have you demonstrated benefit, i.e. your program works, it does what it says it was going to do? And if you haven't, you need to understand why. Did we take on too much? Did we overpromise? Did we do something wrong? Were there some external influences and so forth? Because you're going to have to understand why and retool, refocus, and or try again. But you're also going to have to tell people why, so that they don't see it as a failure because if they see it as a failure, you're unlikely to get a second or even a third opportunity. Secondly, you have to tie to the benefit from a clinical point of view. You also have to demonstrate value, and there's different ways to explain that. But you know, with economies the way they are, with the pressures and the sensitivities in the healthcare system, everybody wants you to do more for less. They'll take more for the same amount. They're not too receptive to more for costing more unless you have a pretty good case. They may accept a surge, a spark, an initial pilot where there may be some upfront costs, but in the long term, there's not too much receptivity to budgets going much higher, at least at the beginning. But if you can demonstrate benefit, if you can demonstrate value, tying those benefits, what is the cost or the successes that you can tie to that for the system and for the administrators, the people who drive that system, that's off to a good start. The next thing is you need to share what you've done. So you have to advise people, tell them, promote what your program does, the good that it applies from a clinical point of view. Everybody likes a good story because that's sort of who we're made of, and the fact that we can help patients and their families and such, or populations of patients, but also the value to the healthcare system. And this is sometimes tough because you need to get in front of the right audience. I think as Dr. Rocker mentioned, you have to talk not only to your peers and colleagues, but also above and high enough above to kind of the decision makers. And when you speak to what you've done and what you're doing, you're also going to sort of speak to what you'd like to do. And so you need to have, and that's you and your entire team, and you will not do this by yourself. You need to have your entire team on side, and they would have participated and feel to have been participants in the process, have that same plan for growth, for alignment with other programs, with alliances and so forth. And that plan has to be doable, it has to be believable, it has to be scalable, and you have to be able to measure benefit for two reasons. One, to make sure that you're doing what you want to do so that you know as opposed to just believe. And you also have to share those measures, and they have to be measures that are valued by others. Because the decision makers, or as George Bush would say, the deciders, aren't going to back you. They aren't going to support you. They're not going to send you budget unless they believe that you can do what you do. They believe that you are trusting and competent and so forth, and that the plan is both scalable, and then because they have accountabilities as well, so it has to be measurable as well. They don't want to feel vulnerable. They don't want to feel like they're taking any risk, and so the surer you can make a plan in these endpoints would be very good from your point of view. So let's say that you've done that, and if you haven't done that, you've sort of got to go through these points and make sure that they are addressed. Next slide. So in terms of holding the gains, reality, as we know, is you're always under the threat of extinction or scale back. And, everybody in the healthcare system, this year is worse than the last year. And you keep on hearing that. But those of us who have been around, long enough know that every year is the same. The budgets are different than they used to be 20 years ago. The pressures are different. The realities are different. It varies from year to year based on, some of the realities outside in terms of what government and deficits and stuff. And there may be more people that are more effective in communicating what that risk is and what the differences are. But it's, there's a cycle to it. It happens all the time. So you need to keep demonstrating that benefit. You need to keep telling people how good you are. So how can you do that? Because you don't want to just be, it can't be one person at the same venue because you wear out your welcome pretty fast. So what gives you credibility? Well, annual reports are very good. In fact, that's been, someone once told me that it's probably your biggest ally. And in fact, I think it is. Because you're proud, you are opening up yourself to external review, and you're sharing with people what you are doing and the good that it accomplishes. But you can also complement that with newspaper op-ed articles, having patients speak on your behalf, having advocacy groups or patient advocacy groups speaking on your behalf, and the more the merrier. Never overstate, don't lie, because you'll lose credibility. But anything you can do and others who can help you in doing that will be very helpful. And you need to continue measuring in some respect, but you have to tone it down after that initial benefit has been demonstrated, because you're just going to get measure fatigue and you're not going to have any capacity to grow or to measure new things. And the perfect analogy, and there are many, we now accept that, aspirin is pretty effective for acute coronary syndrome. So, every health region, every institution doesn't look at the mortality benefit of administering ASA in the setting of myocardial infarction. They eventually believe. And they go on to measure other things. Well, do the patients receive? What are the barriers? Those sorts of things. And life goes on in the cycle. Similarly, for your program, particularly if you're going to try new things, you're going to have to measure new things, and you need capacity for that. It was alluded to, the developing and strengthening partnerships. You need friends, you need allies who will also be able to not only advise and make you better, but also share with others. And even if you don't have a strong partnership, you want to be able to minimize or put a cap on any negativism that goes. When you're going forward with a proposal, and if the healthcare system, i.e. administrators, hear anything, particularly from close allies, colleagues, and so forth, that speaks to conflict, that speaks to they have a different idea, they're not going to go forward, because they want safety, and they want to know that everybody in the field, all the experts, believe the same thing. So that's why, going back, you got to make sure that everybody is involved. One, for that, but two, to make sure it's the best proposal. And you have to remain focused. You shouldn't do more than is important, even though it may feel good, because it really doesn't make much of a difference. It hasn't been shown to be of any benefit. And in doing so, you have to be kind of strategic, almost tactical. And at the very beginning, when you have very limited resources, and those little things make a difference, you almost have to be tactical to a fault so that you stay focused. Because as soon as you start to dilute, then the potential benefits are also at risk. So that'll help you in terms of building capacity and knowing what enabled you to grow and to extend the reach. Next slide. So if you're in that situation where, in fact, someone is considering growth and it starts from within, this is the fun part. It doesn't always happen. Your dreams don't always come true, but this is where you start to sort of look at the possibilities, to design the future, to sort of influence what might be. And if you're successful in this part, you've made a huge gain, because you now have credibility, you have trust, and people will start to come to you when this happens in different settings and in different points in time. So this is going to be driven by a plan, and you can call it what it is, but there needs to be short and medium term wins with various checkpoints and pauses to make sure you're on task, and if you're not, to sort of get you back on task, as well as some long-term aspirations. And those endpoints, those aspirations, again, have to be centered not only on the patient or populations of patients, but also on the healthcare system. So what would do the most good? What would provide the greatest benefit and value in terms of what you're doing? So there's all the issues of, exactly what it is, but also how to operationalize, how to look at barriers and such. And so you're looking for some quick wins. Can you have your cake and eat it too? And so sometimes a single intervention, a single move, a single policy can have far-reaching consequences, benefits that extend beyond one or two or three things. In our example, one of the most strategic, smartest things we did was to look at exercise reconditioning. We didn't call it pulmonary rehabilitation, because that centered it just on COPD and other conditions, but it kind of took it away, separated it, marginalized it from cardiac rehab and diabetes and rheumatologic conditions and so forth. And so it became a central theme. And when our program is being done, we have the same staff, we have the same center, the same design, the same delivery, but we've given everybody kind of a different color T-shirt. So that's their sense of identity. And there's some things that are unique to each one. The defibrillator's a little closer to the cardiac population. The oxygen's a bit closer to the lung population. But we were able to, with a single intervention, marked efficiencies, help a number of streams. And then the last thing is, do you have something, it may not be perfect, but it is a start where you can borrow, you can enhance, or take ownership in a very positive sense, something that others are doing. And again, this is what we've done with some of the other work that others have put a lot of hard effort into in terms of promoting self-management, self-efficacy, and understanding from a patient-centered point of view. The last thing I just wanted to touch upon are just some overall kind of learnings. And this is, some of these were learned on the next slide from a hard point of view, and others were advice that we, received from others. There is a desire, it's a practice really, to almost start from scratch every time. We need to do what happens for ours, and what they do in another region, another province won't apply to us. And it's almost to a fault. While I can understand, and everybody should personalize, there is benefit in borrowing, stealing, copying in right ways efforts of others. And you do get to a point where when you're asked to review or assess or to provide comment on programs or offerings in different cities, different provinces, in Canada, the United States, and internationally, there's a lot of common themes. And some people have done very well, and you can learn from them. Others are still have some work to do, and you can teach those people. But I think that's a pretty good thing to do, and this is part of what this program here is, and that there's learning from the various 19 programs across the country and some of the successes others have had. Certainly from a basic point of view, it's pretty efficient to do this, because the more you start from the beginning, the more you use resources and effort, and you just get tired and you get weary, and the people around you do the same. You can also utilize things like site visits, so have somebody come and comment, and you have a little report generated, and that gives it credibility. You can have external program reviews, which people will come and probably do quite willingly, because they do want to help. Out-of-town experts can be helpful as well, not only to provide an external eye, but also to share with your own administrators that the fact that you have credibility and you're trying hard and such. And their safety has been mentioned in pilot projects. Because they're short-term, it's easier to get funding for a pilot project. It's quite focused, and that can sometimes lead to the more sustained base funding. You need to surround yourself and stand with good people. And this makes it easy. If you're not surrounded by good people, you've got a tough job. A weak team member makes for a weak team. It really does. And similarly, if you're surrounded by people who are so effective, who are just leaders and they're doing all the right things, it's good. We were successful in really moving forward with a dyad leadership, and there's lots written about this and lots have done, but it really helped, where you had a healthcare administrator teamed with a clinician, so either a doctor or a nurse, and always seen together. It shared and signaled interprofessional and interdisciplinary care and harmony. It reflected what the team was about. It allowed us to speak to different audiences at different times. So there are times when you don't want the doctor there. There are times when you don't want the administrator. There are times when you want both. And so we were pretty good in that regard. You need to be a good listener, because there are times when what you're trying to do can help others. And if you can solve multiple problems just by doing what you wanted to do, you've got a friend or an ally, plus you've done some good along the time. And then finally, you need to learn, and this is the toughest part, the patience, because this takes time. You're not going to have a big, successful, far-reaching program in 1 month or 1 year. And it's going to be frustrating, because you're going to deal with people who maybe don't understand, or might be actively trying to limit what the possibilities are. So you always have to act like a leader, always. You rarely get what you want the first time at the beginning, so you need to manage expectations as well as the expectations of your staff. And in doing so, you will establish and build trust. But at the same time, that doesn't stop you from being an effective advocate, always moving forward, albeit in baby steps at a various time. So maybe I'll stop there and hand it over to Jennifer.
Darcy, thanks so much. Really practical, and I'm pleased we've got, I think, about 16 of the teams of the 19 participating today, and hoping to see the remaining teams join the call tomorrow, but this is just like really practical advice at a time point when they're thinking exactly these things. So one of the questions that we asked them was about what do they need, and Maureen Black from Health PEI made, the comment that they need permanent resources beyond the project. I'm just curious to know, how were you able to secure that from sort of initial idea of improvement, piloting, to permanence?
Yeah.
It's a big question, but I know that's what's on people's minds because the seed funding has run out.
Yeah. So, I'll be fairly tight in my response. I think I would use the results of this initial project and hoping that they were positive, that you demonstrated benefit. You're probably not going to have a whole cost analysis and so forth, but you can use some of the data that Dr. Rocker and this program is putting together to help you. You need to advocate and talk to your, direct reports and the administrators to try and say, we did this good. Let's fund it for a year, extend the pilot, whatever the case, and maybe grow or reposition it. Second thing you can do is you can also look for some other people who might be able to provide some seed money. So like Dr. Rocker, we were very fortunate. The pharmaceutical companies were willing to invest a little bit of money at the beginning so that we could demonstrate some extended benefit. And not within 6 months or 12 months. After the very first spark, we said, let's look at 18 or 24 months. So that extends it a little bit longer. And then once you are able to demonstrate some value in a small way, we didn't solve the whole COPD problem, but we focused on a high-intensity, high-use, high healthcare utilization population, and at the same time softening up not only locally but also provincially and beyond, then that base funding in small ways occurred. And then over time it expanded to where we are right now. And others, once you have a bit of an identity, that brand is quite positive, then others want to come to work with you, and your job gets a little bit easier from that point of view.
That's really helpful. Thanks, Darcy. And I just flicked to your picture here, which is really nice. Nice transition as we move over to Stephen, who's going to talk to us a bit about, to bring us back to the topic of conversation in terms of scale barriers, what return means in a healthcare context, and some considerations as teams are developing these business cases. So thanks very much. We appreciate that. And over to Stephen.
Great. Thanks very much, Jen. And thank you also to Graham and Darcy so far. Much of what we're going to talk about in terms of building the business case and actually trying to move into scale has been very well covered under the slides that you've already presented. The Federal Innovation Panel, led by Dr. David Naylor, which was referred to earlier by Jen, identified a number of barriers to scaling up innovation in the Canadian context. And this is basically a summary of what they had said were some of the real barriers. Importantly, in their report, they also noted and identified Inspired as a model of care that had seemingly overcome those barriers. And then through your work in the collaborative, you have actually managed to demonstrate that it's possible to adapt and adopt new ways of working in care. So, these are the kinds of things that exist within the Canadian healthcare environment, but we've already shown that we can get past those things and move into adapting and adopting new ways of working. And part of the way in which we did that was through the use of PDSA cycles and that kind of way of thinking about improvement. And I think it's probably fair to say that this is covered off. What we see in this slide is actually kind of a pictorial representation of the kinds of things that Darcy was talking about in the assumption slide. So going back and forth and toggling back and forth between what's in that assumption slide and here, you really will start to, we really start to see what we're trying to do in terms of retesting and reevaluating and strategically planning and engaging and then moving forward. I think it's fair to say that for the teams, we're pretty much at the implementing a change stage, and what we're really trying to do here is think about how we can use the method of PDSA to move into scaling and spreading. And some of that is about engagement. It's about the planning. Who do you need to engage? Who needs to get involved? Who are your champions? What do you need to do, and what time frame do you need to do it? How are you demonstrating further impact, as Graham talked about, over the course of what they've been doing and Inspired? And then how does that allow you to then continue to move out and build out the program? And it's that constant evolution that's really required as we move into scale. So the next slide is some of the prerequisites for moving to scale. And again, I think that this well encapsulates some of the things that were in the assumption slide. Excuse me. And that is that, this is a summary of moving to scale done by the Institute for Healthcare Improvement, and really just basically saying what Darcy and Graham have just talked about, but particularly what Darcy was talking about in terms of this needs to be an organizational priority. You don't want to be swimming against the current here. You need to be capitalizing on a priority within the organization. And you need the commitment of the leadership, but you also need to help the leadership sometimes to build their commitment. And it's through the demonstration of value that we've talked about so far that you can actually get that buy-in and that commitment when it's sometimes lacking. And then building, really this next thing is really knowing your organization and some of the things that we just saw on the lessons learned slide, really building on the conditions for success within the organization, knowing who to talk to, when to talk to them, how to speak to them, how to engage them. And again, this is what we're trying to do. I think it's really important in a nutshell. This represents what we've been measuring throughout the collaborative, and it really does create the winning conditions for spread and scale, and that is the triple aim of improving health, improving the patient experience of care, and showing that this is good value for money. This is how we've largely been measuring throughout the collaborative, and that needs to continue going forward in just the ways that Graham and Darcy have talked about. So in terms of developing a successful business case, it needs to be a priority of the organization, consistent with where you're trying to go, and those triple aim legs on the stool are a great way to plant. Those are great poles to plant down. That's where you want to go. You want to improve the health of your population, improve the patient experience of care, and get better value for money in the systems that we already have. It needs to be well conceived. It needs to show that it's feasible, and through your demonstration of the work that you've done already, you've demonstrated the feasibility. It's now building on that demonstration. And again, the ROI that we've seen here and that Graham continued to talk about in his slides is really building value from the funder's perspective or from your leadership's perspective. There's really this is a no-lose situation when you demonstrate the value for money. And I think this goes exactly to what Darcy was talking about in terms of the expectations that you're setting out, being really careful not to overpromise and underdeliver, but exactly the opposite, and to do that really intentionally and carefully. So typical elements of a business case are you need to talk about your organization, how this fits into the priorities of your organization, how this is enabling your organization to move in the directions you've already stated you're trying to move in. It goes right back to things like annual plans and the ways in which your organization is reporting both internally to itself and then publicly to its citizens about what you're trying to achieve. You need to be very clear about what the project description is, what your sustainability plan will involve, all of the financials that are involved in this, and the improvement measures and evaluation, how you're going to manage this and oversee the ongoing spread and scale of this, and what the approval process looks like. And I think this echoes many of the lessons learned items that were presented by Dr. Rocker. And again, all of this speaks to something that we have been absolutely fixated on throughout the collaborative, which is the importance of data. And when Graham presented the data there, you see the compelling case. It's right before your eyes. It's really hard to dismiss that, and that's why the data is so important. As the IHI has said, there's no end to the improvement we can do, and we need to make it a priority, but we also need to make it a win-win for all involved. So just to stop there and see if there are any further questions.
I'll just say there's a couple comments
Okay.
that have come in. So from the Citoisesse of Pierre de Sorel, someone's mentioned, I do hope that the efforts are aligning with what each team set out to do last year. And it is an important opportunity to reflect on your own journeys in this, in creating those winning conditions, seeing some of the early gains, which vary. If we asked everybody the question of, and we did in your final report, what was the most significant change that you observed over the course of the collaborative, the answers are different. And I think it's an important point to reflect on and to similarly ask those who hold the purse strings or play some role in sustainability, what are the types of real outcomes that they would like to see realized to sustain efforts like this is important. Are you measuring anything that will be able to help you report on those types of indicators, for example? Wendy Laframboise from the Ottawa Hospital, and we're going to hear from Sherry from the Ottawa Hospital tomorrow in more detail on this in terms of what they're doing to sustain their efforts and spread. But she says very practically that, even though TOH is now in a position where they have 12-month data, they certainly are doing quite well in this collaborative and are certainly one of the front runners in terms of being able to get out the gate early on and see a sizable number of patients. They're currently collecting data to present a case costing analysis to their administrators. That's one of the missing ingredients that they need to be able to demonstrate the value for money, the return on investment. And then additionally, they have a number of meetings, some of which I think Beringer Ingelheim, Healthcare Affairs Manager James Thompson helped to organize here in Ottawa with the local health integration network or the region. So, pulling on your allies and your partnerships and friends are really critical at this point, and balancing the need for measurement, what type of measurement, with very strategically making some important moves to be able to get the right people to know what you're doing and what it's realizing by way of improvement for patients and families. So would encourage others to weigh in here, but what we've just got in our last few minutes are a couple of examples of what we have collectively gained. We're right now in the process of a full evaluation, of course, and we have in front of us all of your reports and the survey information. We're conducting key informant interviews. We're doing our own case costing analysis. So more to come, but we just wanted to share a couple of quick highlights in terms of reach, readmissions, and what patients are making of this inspired experience as well. So I'll just pass it back to Stephen on reach.
So thanks, Jen. I mean, this is where we're at now, and this is what we have achieved collectively through the collaborative, which is, I think, really, quite remarkable that we have, or in a very short space of time, really, when you consider it, now have 670 patients enrolled across the country. What we're really trying to talk about here today is how do we turn that 670 into 1,670, and then ultimately into 6,700. How do we continue to roll this out and make this the way that people living with advanced COPD are properly cared for in the Canadian context? So that's what we're going to try to do, and then I'm going to turn it back now because we're going to ask Graham to help us to consider further some of the data that can help to build that case for the continued rollout.
So Graham, we're going to pass over to you before we share that readmission data, which I think you're going to share as well from the 16th.
Yeah, so looking back, this is an analysis about a year or so ago from a cohort of patients who had completed all aspects of the INSPIRE program and had survived for 6 months and longer. And I was interested to know at this point, well, okay, so we have pretty good data 6 months before and 6 months after INSPIRE. What does it actually look like if you go back a year and you go forward a year? And what this slide, I think, demonstrates quite nicely, and this is, I think, important in the coping with some of the arguments that you might hear when people say, well, you'd expect a reduction after admission. Not everybody gets readmitted after an index admission. If you look at the 12 months before INSPIRE data, at the top half of that slide there, where I separated things out into a period 1 year to 6 months before INSPIRE, and then 6 months to the time of the admission, the index admission, you can see that there is an acceleration of facility usage as time goes by, the closer they get to the index admission when they became enrolled in INSPIRE. And I think this is important because, for people who are within this MRC 4 or 5 kind of category, there is an expectation that once submissions start happening, they are going to become more frequent as time goes by. And I think this is quite a nice demonstration that that does seem to be the case. So, hang in there, for longer than your 3 months. We're currently dealing with 3 months follow-up data. Hopefully we'll get 6 month data, and at some point possibly a year data. And so when I looked at this data over 12 months and then sort of broke it up again after the INSPIRE program, you can see the kind of change in red there. You know, if we just look at the 6 months, we're dealing with a 72 and beyond % reduction in usage, and even when we look at a total across a year, we're still looking at 50-60% reduction. So, you know, it's the accelerated reliance on facility as time goes by that I think is sometimes important to highlight. And that's in the context, I think, of, you know, when one looks at some of the data within the collaboration here. And so here we have data on 146 patients from 6 teams within the collaborative. This is basically a 90-day comparison before and after. It's a pretty good start when you come to think of it. 180 admissions before and only 33 afterwards. So there's been quite an impact there. If these patients are the same type of patients as we saw in Halifax, and I can't say for certain that they are or that they're not, they might be, but it's just worth bearing in mind that, again, this might be a cohort where you would expect there to be readmissions at a much higher level than 33 versus 180.
Thanks, Graham. Oh. I seem to be stuck here. Sorry, just want to pass it back to Stephen here.
So thanks again, Graham. So again, you see here a real sense of how you can use the data to your advantage to really build the case that there is a really important reason for doing this. You can also look at things like the reports that are already in the environment, like the report that came out yesterday by Walter Woodchus in Ontario, which again demonstrated that 5% of Ontarians account for 65% of healthcare spending. And again, that report noted, just as all of you know, that the resources spent on high-cost healthcare users included hospitalization and long-term care. And so again, this is part of the growing knowledge base of healthcare in this country, that we're not providing the right care at the right place by the right people at the right time, and we're paying the price. And you are demonstrating through your data that you have and the kinds of data that Graham just demonstrated, the case for doing things differently. So the quantitative data is crucial, absolutely crucial. Your bean counters are going to want to have that quantitative information. That is a huge part of the business case. And as equally important is the qualitative data. The quantitative data speaks to our minds, and the qualitative data speaks to our hearts. And you need the qualitative, you need the heart-based information, the qualitative data in your business case. And don't underestimate the importance of the qualitative data, the personal stories, what this actually means to patients and their families, because that's really why all of you are in business and why all of you go to work every day, to improve the lives of patients and families. And when you can demonstrate in ways that really pull at the heart how you've managed to do that, like these quotes are, now I'm able to think about what my possibilities are and the smart way to do it. I went back to work. You sent me an angel. Attending my daughter's wedding was the best day of my life. No, it was the best day of all of our lives. I've been able to enjoy a quality of life I thought I would never had. This kind of data, the qualitative experience, is absolutely crucial and definitely needs to be built into your business case. It complements, it's not an instead of the quantitative data, but it's the complement, it's the human interest. It's what gets so many of us, it's what can sometimes be the tipping point in getting somebody to say, you know what, this is the right thing to do. Let's do this. So always being mindful of those patient stories. And again, in another way in which the foundation is, CFHI is interested in helping continue to pull this forward and help set the stage for scale across the country, is that we're really interested in doing some videography work with your patients and actually speak with patients and family members who have been part of the collaborative, whose lives have been touched by the ways you see on the screen, and really try to create some of that qualitative demonstration of value as well.
Really nice, and I think that's a great place for us to leave today's call. We're going to pick it up again tomorrow, same time, same place, but we're flipping the classroom. We're going to hear from the team, so particularly from the Ottawa Hospital, Joseph Brant Hospital, and we're going to hear a different perspective than we have previously from Nova Scotia Health Authority, Graham's neck of the woods. We're actually going to hear from an administrative perspective on those questions that Darcy addressed so helpfully earlier in today's call. So please join me in thanking today's speakers. I look forward to reconnecting with everybody tomorrow, and I'll also share some highlights of upcoming key dates on tomorrow's call. As we continue to connect, we want to find opportunities to have these conversations so we can collectively help one another field this I think, tricky landscape of sustaining what you've started and actually reaching for greater gains. So thanks, everybody. Appreciate it. Talk to you tomorrow.